Hello, my name is Edith Johannes. I am a nurse practitioner at UCLA Health. I have been working with liver disease and liver transplant patients for about 17 years. Despite my many years working with liver disease patients, there is one area that I find especially difficult to navigate. The topic is that of alcohol consumption in patients with steatotic liver disease. I will start by giving you abbreviations of three steatotic diseases that I share many features and for which effective screening and quantification of alcohol use is essential, and that you will hear me abbreviate. They are metabolic dysfunction-associated steatotic liver disease is abbreviated as MASLD. Metabolic dysfunction-associated steatotic hepatitis, abbreviated MASH. Alcohol-related liver disease, you'll hear me say ALD. And metabolic dysfunction-associated alcohol-related liver disease is abbreviated MetALD. Most patients do not want to talk about their drinking habits. But as clinicians, we know this is of dire importance because in these patients, if alcohol consumption is greater than the acceptable threshold, it adversely affects disease progression and potentially treatment. MASLD patients are those who have steatosis plus at least one cardiometabolic risk factor and no history of alcohol use or minimal alcohol use. Less than the acceptable threshold is what we consider to be minimal. To review, the metabolic risk factors include increased BMI greater than 25, hypertension, diabetes, high triglycerides, or low HDL. ALD patients are those with steatosis plus alcohol consumption, but without metabolic risk factors. MetALD are patients who have steatosis plus at least one cardiometabolic risk plus mild to moderate alcohol use. Okay, that was a mouthful. What I'm saying in simple words is that MetALD patients lie in between the MASLD and the ALD patients. We can think of MetALD as a diagnosis that combines MASLD and ALD, but that is not really accurate. MetALD has recently been established as a standalone diagnosis due to mainly the unique effects that alcohol has on metabolism. To distinguish between MASLD and MetALD, an acceptable threshold for alcohol consumption in MASLD has been established, and that is less than 30 grams per day for males and less than 20 grams per day for females. It's important to note that MASLD and MetALD share risk factors, pathophysiology, histological features. A biopsy would not be able to distinguish between the two, even though a biopsy is the gold standard for many of these diagnoses. This is a reason that accurate assessment by means of history taking is crucial. When I say accurate, I'm talking about quantifying the amount in grams. I know what you're asking yourself. If MASLD and MetALD share risk factors, pathophysiology, and histological features, why is it that crucial to quantify alcohol consumption? That's a good question. MetALD is a diagnosis that lies in a continuum, something that changes in character gradually. As a provider, you will need to adjust your clinical judgment, strategies for surveillance, and interventions depending on where they are on this continuum of alcohol consumption. The elements in that continuum are the grams of alcohol consumed per day or per week. So you could have two patients, both with MetALD, but one who is predominantly leaning towards MASLD and one who is predominantly leaning towards ALD. Before I move on to treatment, though, which is very important, let's go back to the challenge of talking about alcohol consumption and ways to be more effective in screening and quantifying it. I'll start by saying that there is no one correct way to have this delicate conversation. Motivational interviewing has been proven to be effective, and I encourage you to use and practice it. But there are a few things that I share that I find valuable and effective. I think that learning how to build a positive rapport with patients in a very short amount of time is essential. It's important to be honest, respectful, and sensitive. One must be able to adapt history-taking skills to the patient's level of education, culture, gender, and social norms. For example, I will use a very different approach with a 55-year-old Caucasian female who is a lawyer compared to a 55-year-old Mexican-American male who has less than high school as his highest degree of formal education and works in the fields. However, my goal for both patients is exactly the same. to screen for alcohol use disorder and gain the most accurate insight into the quantity of alcohol they consume. There are various screening questionnaires available and validated, and I urge you to use them. There are things like CAGE, AUDIT-C. They are accessible and easy to use. I think what is more difficult to do is to quantify, because inaccurate self-reporting of alcohol is very common. It's usually due to underestimation or even recall bias. It is important for us to anticipate that the responses we will get are going to be vague. So honing in on specifics is imperative. But how specific do we really want to be? Remember that continuum I mentioned earlier? Well, we want to know where patients fall in that continuum. And remember, the elements are grams of alcohol. So we want to know how many grams of alcohol a patient consumes in a day or in a week. What makes it even harder is that there is no consensus on how many grams of alcohol constitutes a drink. In North America and Latin America, we use 14 grams, while European guidelines state that 10 grams of alcohol is considered to be one drink, and other places even use 8 grams. So for our session, we will use AASLD recommendations, and that is that one drink is equal to 14 grams of alcohol. Another fun fact is that no one ever says, I went to the bar and ordered 14 grams of alcohol twice, right? No, our patients don't say that. What we hear is, I drink socially, or I drink once in a while, or I have between 2 to 3 drinks on Friday nights, or I drink almost every day, but it's not a lot. Well, it is our responsibility to make them be specific. Ask, what is a drink to them? Is it a beer? Is it a cooler? Is it a whiskey? Is it a wine? Every type of alcohol beverage contains a different amount of alcohol. For instance, there's about 14 grams of alcohol in a 12-ounce beer, but those same 14 grams are found in only 5 ounces of wine, or only in 1.5 ounce of hard liquor. It is also important to ask about the size of pours and containers. For instance, not all beer comes in a 12-ounce can. I learned this from a patient. He told me he only had 2 beers every night after work. I quickly did the math and I thought, okay, 2 beers, 12 ounces each. I thought, yes, that is below the threshold, and he drinks about 28 grams of alcohol per day. I found out very quickly that he was drinking a crowler, which is a 32-ounce beer, on a daily basis. So he was having way much more than what is threshold. Again, understanding the quantity of alcohol consumed will allow us to identify if a patient has a diagnosis of MASLD alone, MetALD, or ALD. Okay, the importance lies in that alcohol consumption clouds the patient's clinical picture. Alcohol consumption will affect diagnostic testing and in turn can affect treatment options. For instance, alcohol use will persistently increase LFTs, and it will be difficult to know if that persistent elevation is because of chronic disease or if it's just from the persistent injury that is happening and inflammation. And specifically, you may see persistently increased ALT and AST levels, which will affect the results of a FIB-4 test. Alcohol use also leads to a persistent inflammatory state, and inflammation makes the liver stiffer. So when non-invasive tests are performed, they may be inaccurate. This happens with elastography. The results may be erroneously high. Unfortunately, MetALD patients may have results that suggest that there is more fibrosis than there actually is. Why is this important? Well, because it will affect our treatment options, right? Somebody who has MASH may be eligible to be started on resmetirom. Somebody who has MetALD with leaning towards MASLD predominantly may also be treated with pharmacotherapy, but somebody who has higher non-invasive testing may not. So it is very important for us to identify that. Before I end the discussion today, though, I want to go back to liver disease progression and MetALD, because it is important to know that there are detrimental effects when there is concurrent significant alcohol use and metabolic dysfunction. Studies have shown that MetALD is associated with more liver disease progression and more severe outcomes. MetALD is associated with all-cause cancer. Recent studies are showing that there's a stepwise increase in the risk of developing hepatocellular carcinoma. MetALD is associated with increased cardiovascular disease. They have a higher risk of cardiovascular events than those patients that are MASLD alone. MetALD is also associated with increased mortality risk, both liver-related mortality and all-cause mortality. Because of the increase in risk progression, initiating treatment as soon as possible is important. I mentioned treating MASH with lifestyle modifications, and that is primarily weight loss and resmetiroms. But I also want to mention that alcohol cessation is very important. But of course, this is easier said than done. Changing habits is very difficult and a lifelong struggle. And as providers, we need to acknowledge effort, embrace that any amount of decrease in alcohol consumption is a win. Helping patients to cease alcohol consumption is best achieved with a multidisciplinary approach. And I'm talking about including other disciplines like social work, psychiatry, substance abuse experts, because they can help us identify triggers for drinking. They can help us identify their support system or enrolling them in an AA program or something similar. They can also help us identify other medical problems that affect the drinking, like depression or anxiety. And substance abuse experts can add pharmacotherapy, which will help them to cease alcohol, decrease those cravings, and perhaps maintain that sobriety. As you can see, the topic of alcohol consumption in MASLD is complex. To summarize, I want to point out that patients with MetALD and those with MASLD who are drinking above acceptable thresholds will have a quicker progression of liver disease, higher risk of mortality, and are more clinically challenging because alcohol directly affects risk stratification, like the FIB-4 test and like elastography. And this in turn leads to difficulty identifying accurate degree of fibrosis. Therefore, I urge you to be more clinically in tune to accurately diagnose MASLD or MetALD. And to do that, quantifying alcohol is where we start. Remember that overestimation of fibrosis could inadvertently lead to not offering pharmacotherapy, proven to be beneficial in MASH patients without cirrhosis. Thank you so very much for spending the time with us here at MASLD MASH Community Network. I hope to see you again when our efforts to continue learning. Thank you.